we're going to talk about PJP today, a lot of the literature behind it, epidemiology, things like that. I have a few board review questions in there too. I know I've used the Poll Everywhere software a lot, but if you don't have the app on your phone, you don't have to download it or anything. You can just go to that address right there, pollev.com. There's also going to be a QR code when we get to the questions that I was able to get integrated into the PowerPoint. So you should be able to scan it with your phone too when we get to them. I have no disclosures related to the talk. PJP, like we talked about earlier, is a infection that usually occurs in immunocompromised patients. Just to go over again, the differential diagnosis for pneumonia is extremely broad in immunocompromised patients and can include a lot of other non-infectious things as well, related to drug therapy or treatments that the patients may be getting. And you can kind of see PJP is just this very small little organism on there, but there's kind of some specific risk factors to know about that may clue you in that may be what the patient has going on. And another thing to always remember too, that immunocompromised patients, may present with not only atypical pathogens, but they may have common things and just present more severely. This is for solid organ transplant, just to go over again, where in the timeline after transplant that you have the highest risk of PJP. It's not early on, right after transplant. It tends to be at least a month to 6 months afterwards where you start to have the higher risk of this is an opportunistic infection, but obviously anything that can alter this timeline, if you have liver transplant or a kidney transplant and are getting treated with solumedrol pulse dosing for cellular rejection, that's obviously going to alter your timeline and certainly change things up and be a significant risk factor. Same thing for bone marrow transplant. Very rare early on. You probably see at Moffitt, we don't even start prophylaxis until day 28, day 30 for a lot of these patients because it's very rare to have it before that time period. So just an overview of what we're going to talk about, Pneumocystis Jirovecii. We're going to go over the epidemiology, radiographic findings that are kind of more classic infection. It's important to know that not every patient is going to present with those, but just to give you the typical presentation, I think is important and what usually shows up on the boards. Talk about how it differs in patients with HIV versus those who don't have HIV, like with malignancy or organ transplant, and then talk about the different management and prophylaxis recommendations. So starting with the case, a 28-year-old male with Hodgkin lymphoma comes in with fevers after cycle 5 of doxorubicin, vinblastine, dacarbazine, and brentuximab. Denies cough, nausea, vomiting, diarrhea. He was previously admitted 2 months ago with fever and found to have ground glass opacities on a CT chest, and he was given a course of levofloxacin for pneumonia. He is febrile but hemodynamically stable on room air. The following is seen on a GMS stain of induced sputum. Which of the following would you recommend for this patient? So should be able to, I think you should be able to QR code it. Yeah. I'll go back in a second. Just everybody's have a chance to get the QR code. So. Okay. So going back to the stem. These are the right answer choices.
No, like the answers listed on here.
Not for me.
Not for me. Did you refresh it?
Because when you initially signed in.
Yeah, there was a different question initially when you logged on. Yeah. It was like a cefepime question.
Okay, so we got about 11. Yeah. So we have 18% with amphotericin B and 82% with clindapyrimidine. So clindamycin and primaquine is the right answer. This talks about pneumocystis, and I showed you a nice GMS stain of the organism. Certainly some risk factors this patient has that we'll go into is the B-cell depleting therapy with brentuximab, as well as their malignancy. They kind of came in probably 2 months ago with PJP as well. Fever, diffuse ground glass. They had some immune reconstitution between cycles, were able to kind of control it and then relapsed. Some things that are, potential confounders on this question is, I didn't give you cough. I didn't give you a lot of other things that you may see, but it's kind of a more chronic indolent infection for a lot of patients, although that's not always the case. And we'll go through certain treatment regimens, but the only one of these that's a recommended treatment regimen for pneumocystis is actually D, the clindamycin and primaquine.
Why offer that as a choice and not not Bactrim?
Because it's going to be an ID board question. You're going to have to know when you can't use Bactrim and what your alternatives are.
Oh, okay.
Uh,
Why is he precluded?
So I didn't put anything in the stem, but I mean, there are
Oh,
some certain
okay,
patients.
that's where I got confused. I'm all
Yeah.
like, okay.
He's just trying to see if we do third line treatment.
I was about to say, because and that's what confused me is I'm sitting there going, is there something about the chemo that is?
Nope.
Okay.
No, he's just giving us third line treatment.
All right.
But there are certain situations, like let's say a patient has to get methotrexate for whatever reason. You can't use necessarily Bactrim. Let's say that they have a history of Stevens-Johnson's from Bactrim, or they have severe hemolytic anemia from Bactrim.
Yeah.
So there's situations where you have to know the alternative therapy.
Certainly.
So Pneumocystis jirovecii, this organism was originally actually classified as a protozoan. I don't know if anyone knows what it was discovered in 1909, what they originally thought it was. It's kind of random trivia. But when it was originally discovered, it was thought to actually be Trypanosoma cruzi. And that's why for just the longest time, it was thought to be a protozoan until we got to be able to better characterize it. And it actually is a fungal organism. Pneumocystis carinii is the one, that was kind of the umbrella term for all of these organisms, but there's almost a specific one to each mammalian host. And carinii is the one that is known for infecting rats at this point, and then it was later determined that the one that mostly affects humans is Jirovecii. And so that's where you had the nomenclature change from PCP to PJP. But despite that, you're still going to see a lot of times PCP used because it's still pneumocystis pneumonia, even though it's not necessarily the specific species. The first case was actually reported in World War II in humans in malnourished infants. And then later we started developing or finding cases in patients with hematologic malignancy. Obviously, with the AIDS epidemic, there was a huge explosion in cases and a better characterization of the disease itself. The classic presentation, which I think is best described in HIV, is this progressive subacute chronic infection with dyspnea, fever, non-productive cough, very non-specific symptoms. But the organism itself is not always clinically significant. So it's, the CDC estimates about 1 out of 5 people at any given time have the organism in their lungs. This is one of my favorite studies kind of characterizing that was published in CID in 2010, where they basically looked at patients who were in Chile and had died in a lot of motor vehicle accidents, suicides, homicides, things that had nothing related to pneumonia or any sort of lung pathology. And a lot of them had not only the organism detected by PCR, but by immunofluorescent staining. And so it's a potential commensal organism in the respiratory tract. And so just isolating it from from a sputum sample doesn't necessarily imply disease. You really have to have some sort of evidence of a pneumonia or risk factors for the disease. In terms of who gets PJP, so this was a study of kind of trying to characterize what the risk factors were in patients without HIV. We know that's a huge risk factor. That's probably 30 to 40% of all cases. The biggest risk factor for the non-HIV patients seemed to be corticosteroids. So 88% of the 321 patients in this study were receiving corticosteroids. You see a lot of organ transplant, even some solid tumors. And then in terms of hematologic malignancies, lymphoid malignancies were the predominant ones. So 72 of the 84 cases, a lot of Hodgkin's, CLL, things like that. Myeloproliferative diseases, AML, MDS, it's still possible, but it's a lot lower risk than some of those lymphoid malignancies. And then some of your rheumatologic diseases, connective tissue diseases, things like that as well. In terms of another neat thing the study did was compare the presentation from a patient with HIV to one without HIV. patients who don't have HIV and develop pneumocystis pneumonia, they tend to have a quicker onset of disease progression. So, instead of 30 days from onset to diagnosis, it's 7. And that was statistically significant. They're less likely to have cough. Basically half of patients without HIV and pneumocystis did not have cough. And they also tended to, be diagnosed quicker. There's a lot of factors that go into that beyond just medical, but just knowing that it's kind of present potentially even more acute in patients who don't have HIV. Treatment ended up being delayed, though, in patients without HIV. It's not completely clear because, this is retrospective. Is that from delayed diagnosis, delayed recognition? Because it's, we all kind of know HIV/AIDS is a huge risk factor, but it's a lot of times a more subtle diagnosis in patients without it. Their mortality was also higher as well, so 4% versus 27%. And these are the things that they found in multivariable analysis that were independent predictors of death with PJP pneumonia. So certainly you can see here kind of the two I highlighted. I mean, a transplant obviously was a higher risk, but if the patient came in needing oxygen, that was a higher risk of mortality. And then basically each day that there was a delay to diagnosis, that increased your mortality too. Delay to treatment. You can kind of see that in the graph over here, where they break the treatments beginning by day 5, but after day 5 especially, you can see that drop off in the survival curve. So recognizing this quickly and starting treatment does have a mortality benefit. And it is important to know that, while hyperacute, the patient is just sitting there fine and then is in the ICU 12 hours later, that's not likely PJP. But a patient who doesn't have HIV can present with a shorter duration of symptoms, a few days, a week, not necessarily that months or weeks that you see sometimes in HIV. The imaging findings, classically, it's described as bilateral interstitial infiltrates. They may be described as reticular, granular, ground glass. The cystic part about it, the pneumocystis pneumonia, is more seen in HIV. You actually rarely see cysts in malignancy-associated cases. There tends to be an upper lobe predominance, and a lot of that's because of aeration and then just where the organism is. Spontaneous pneumothorax is another classic presentation that may show up on the boards to key you in on thinking about pneumocystis, especially in HIV. Here's some images. You can kind of see the fine reticular interstitial changes. There's even some cysts, especially in the top right. You can see a really nice cyst in the upper part of the image. But nothing's always perfect. These are just kind of classic images. In terms of prevention, we have for HIV some fantastic guidelines because that's where most of the research has been for this disease. If your CD4 is less than 200, or if your percent is less than 14 and you can't really monitor them, those are recommendations for prevention. That comes from this kind of landmark study in 1997 where almost all of the cases, even in HIV/AIDS, were with a CD4 count of less than 200. So that's where that benchmark came from for the guidelines. Preferred therapy is trimethoprim-sulfamethoxasole. Daily is the primary recommendation, but the 3 times a week is an alternative acceptable recommendation if you're using the double strength dosing. Other alternatives, which I think you'll know a lot of these, dapsone, pentamidine, either IV or injected for, which we do sometimes in transplant patients, and atovaquone as well. So in terms of prevention studies in allogeneic stem cell transplant, we usually provide prophylaxis for these patients. At least 6 months is what's recommended by guidelines, but most institutions are going up to almost a year with that in allogeneic transplant, and autologous, a lot of times it's less. You really should continue it if the patient continues to get ongoing immunosuppression, particularly if it's going to impair their cell-mediated immunity, or if they have ongoing lymphoid issues. High doses of steroids, graft versus host disease might come into play, things like that. The agent of choice, we always try to get these patients on trimethoprim-sulfamethoxasole because it's just a better agent at preventing infection. And so this is a study from 1999 looking at dapsone versus trimethoprim-sulfamethoxasole. And there was a 7.2% breakthrough rate with dapsone in transplant patients compared to 0.37 with trimethoprim-sulfa. There's another study too looking at aerosolized pentam, which is used a lot. It's inferior. There's higher breakthrough rates. you'll see sometimes that there's this concern about myelosuppression from the trimethoprim-sulfamethoxasole, and providers don't want to use that necessarily. I think it's a little bit, it's not always, people have more concern from this kind of necessary sometimes. But just know that it probably is a better agent, especially in transplant, in terms of preventing true infection. So you really want to try to get those patients on it. Fortunately, we talked about the time frame. You're rarely going to get it before day 30. A lot of those patients that have already engrafted, and so it becomes more of an issue when you have delayed engraftment or some other condition that comes up. In terms of guidelines for patients with malignancy, there's several guidelines, and they don't all match up perfectly, but just kind of knowing what are the risk factors for pneumocystis are important. So we talked about allogeneic transplant, lymphoid malignancy, autologous transplant, high-dose methotrexate combined with R-CHOP. But really just think about things that deplete your lymphocytes and corticosteroids. I think those are the two big things to just remember. So alemtuzumab, which is a conditioning regimen sometimes with solid organ transplant as well, or corticosteroids. The dose, we'll talk about the different guidelines, but it's somewhere between 20 to 30 milligrams per day of prednisone equivalent, or dexamethasone for over 4 weeks. So not just the 1 or 2 doses, but if you're really doing it for more than 4 weeks, that's when you consider prophylaxis. But you'll see there the grade of recommendation is a C. It's not exactly the strongest evidence, but first line recommendation in this guideline was trimethoprim-sulfamethoxasole as well. Second lines listed were dapsone, pentamidine, or etobicoline. And they did recommend continuing for at least 6 weeks after stopping the steroids, and continuing it for longer if there was ongoing immunosuppression, or lifelong. You could consider it if the patient had a previous episode of pneumocystis and ongoing immunosuppression. So that patient who's got ALL on therapy and develops pneumocystis, as long as they're continuing to be treated for their ALL, they should be on prophylaxis, not just after they get treated. This is a more recent guideline that was actually ASCO in conjunction with the IDSA, published in 2018. They don't necessarily go into a lot of the specifics, but agreed that the risk threshold to starting treatment would be about 3.5%. Other times they did say, kind of 20 milligrams prednisone equivalent for greater than or equal to 1 month was a reason to consider for prophylaxis. They recommended, again, trimethoprim-sulfa, but noted that dapsone, pentamidine, and etobicoline would be alternative options. The big thing I would remember from the guideline is that threshold 3.5%. And I'll give you kind of an example with BITE therapy, which is kind of our newer therapies for multiple myeloma, especially. Some of their early trials, while they didn't necessarily give PJP prophylaxis, those patients had over 3.5% in their trial risk of pneumocystis. And so a lot of centers are moving to provide prophylaxis now because of that. So just kind of knowing that number is the party line from ASCO and IDSA. This is from the NCCN, very similar to what you've seen before, but talking about high-risk patient populations, allogeneic stem cell transplant, ALL, you see they have very strong category 1 recommendations. Alemtuzumab, if their CD4 count is also low. Rituximab with PI3K inhibitors. High doses of corticosteroid. Temozolomide with radiation. So that's one that kind of comes up sometimes. If you're just getting temozolomide for a CNS malignancy, you may not need it, but as soon as you're doing that with radiation, you should. That may show up on a board exam because it's a very kind of interesting that you have to combo those before your risk really goes up. And then same sort of thing, trimethoprim-sulfamethoxasole is the preferred agent with other alternatives listed. So rheumatology, this is one that comes up a lot and I think is challenging for infectious diseases physicians. There's no formal guidelines, I guess, from the American College of Rheumatology for when to prophylax patients. A lot of these patients aren't on prophylaxis, even with high doses of steroids. This is one of the largest studies. It was a retrospective cohort study of patients from South Korea from 2004 to 2017. They had, almost 30,000 patients included in the study who were on steroids and had some sort of ICD-10 code for rheumatologic disease. They divided them into low dose, medium dose, and high dose with the cutoffs of 15 and 30. You can tell most of these patients were not high dose. I mean, we still had, though, 1,655 that were on over 30 milligrams per day of prednisone equivalent. They had a pretty strict definition for pneumocystis infection as well. So you had to have not only your microbiologic test positive with PCR or stain, you had to have some sort of clinical symptom and a radiographic finding, and you had to exclude other pulmonary infections. Their prophylaxis regimen there was a little bit different. I think it was one single strength tablet per day, which I think we here use mainly as an alternative regimen, but it is an acceptable regimen for prophylaxis. One of the cool things in this study, you can kind of see as your steroid dose increases, your risk of pneumocystis per 100 patient years goes up too.
Oh.
But pretty interestingly, they essentially had 0 cases with less than 5 milligrams prednisone equivalent. So the low dose group, they had so few cases of actual pneumocystis, they didn't include them in the analysis. Remember, that was less than 15 milligrams in their study. The medium dose group, so that was 1,065 patients of that, almost 30,000 we started with. Only 45% or 45 of them had prophylaxis, or 4.2%, and they only had 5 cases of pneumocystis. All of those were in the group that weren't on prophylaxis. So the incident rate, though, was still very low, 0.5 per 100 patient years. This is substantially lower than what we're seeing in hematologic malignancy and certainly HIV/AIDS. In the high dose group, they had prophylaxis for 18 patients and 34 cases of pneumocystis. So more cases, not surprising. It's a higher dose of steroid, and you can kind of see the dose curve. Your risk goes up substantially. So they essentially kind of took the direction of, let's focus on this medium dose group, the 15 to 30 milligrams, and see is there certain risk factors that are higher risk within that subgroup. And they found that to be in their multivariable analysis, patients who were lymphopenic coming into their steroid dosing, as well as patients who are getting steroid pulse treatment. So that's, microscopic polyangiitis coming in and getting 1 gram of methylprednisolone for 3 days. Those were the highest risk factors for developing pneumocystis actually afterwards. And they had no episodes that were, it's only 5 patients, so it's a very small number, but of those 5 patients, they had to have they all had 1 or both of those risk factors. The very interesting thing in this study is they were unable to show in their regression that prophylaxis prevented the 1-year incidence of pneumocystis infection. And that's in both the high-risk subgroup and the entire population. One of the critiques of it is there was a very low risk or low rate of prophylaxis anyway. And so if you actually had a more controlled study, more patients actually being prophylaxed, could you have shown prevention of disease, which is completely fair, but that's a limitation of a retrospective study. One of the things they did comment on, though, in the patients who were on trimethoprim-sulfamethoxasole prophylaxis is that there was a pretty substantial adverse event rate. So, 33.5 per 100 patient years. If we're talking about that medium group, the disease rate's 0.5, a very huge difference. Those included things like transaminitis, skin rash, thrombocytopenia. And in 9 of the patients on prophylaxis, they actually had to stop it due to the side effects. And so they calculated this number needed to harm of 45. And that was compared to the number needed to treat in the medium dose group of 204 to prevent 1 case of pneumocystis, and then the high dose group 31. So they, acknowledged the limitations of this being a retrospective study, said in the high dose group, maybe it's reasonable to consider prophylaxis because 31 is less than 45, but in the medium dose group, it's really trying to find what's that high risk subgroup, patients who are lymphopenic and getting pulse doses, maybe they benefit more. To give you a ballpark, in hematologic malignancy and HIV/AIDS, it's less than 20, the number needed to prophylax. It differs based on what your regimen is and kind of where you are. But I mean, at least in rheumatologic disease, it's much less frequent than an HIV and hematologic malignancy. So I know we will recommend it generally when patients are on high doses of steroids, but just know it's not necessarily as high of a risk. Maybe we don't need to be as dogmatic about it, but we clearly need better controlled studies to see if there is a population who would benefit. There's one guideline from the European Alliance of Associations for Rheumatology that does say you can consider, not necessarily you should do it, just it can be considered for steroid doses of greater than 15 to 30 milligrams prednisolone or equivalent for over 2 to 4 weeks. And they freely acknowledge in here that it's very difficult to make recommendations because these patients are very heterogeneous based on their disease state and treatments. And so, microscopic polyangiitis getting cyclophosphamide or rituximab is very different from rheumatoid arthritis on 20 milligrams of prednisone a day kind of thing. Okay, so moving on to treatment. So again, from AIDS Info, fantastic guidelines, a lot of evidence in HIV/AIDS where most of this was studied. For treatment of moderate to severe disease, it's 21 days of trimethoprim-sulfamethoxasole, 15 to 20 milligrams per kilogram daily dosing, divided every 6 to 8 hours. Alternative therapies for moderate severe disease include pentamidine or primaquine plus clindamycin. You also know, patients, and if they have severe disease, hypoxia, should get corticosteroids as well because there's a mortality benefit. For mild disease, the duration is also 21 days. Trimethoprim-sulfamethoxasole is still preferred, but in addition to the previous options, you have dapsone and atovaquone. It's important to remember, and boards can easily ask you too, if you've got a severe case, atovaquone is not a recommended treatment option for severe pneumocystis infection. You should really be on one of those other regimens. For corticosteroids, I think this shows up a lot more on medicine boards, but it's still fair game for ID boards. Having a PaO2 less than 70 on room air or a gradient over 35. The dosing is a lot of it just born out of what was used in trials, but a standard is, the 40 milligrams twice daily for 5 days and then kind of de-escalating from there. We don't have great studies in non-HIV AIDS patients. A lot of the studies in transplant have mixed results. Some suggest a possible benefit, some so no benefit. We often do it, especially in severe cases, and just kind of extrapolate from this, but just know the evidence isn't really as strong in non-HIV patients. Those are two of the big New England Journal studies that kind of showed, hey, there's a benefit for steroids if you want to go back and look at those too. This was a meta-analysis that was published recently in Open Forum, kind of looking at, do we have to be as aggressive with this dosing of the 15 to 20 milligrams per kilogram per day, which is in the guidelines. They didn't find a mortality benefit at a reduced dose of, so the kind of 9 versus 11%. But there was a reduction in the amount of grade 3 or greater adverse events. And so being on that higher dose, there was an absolute increase of 18% with the number needed to harm calculated at 6 to develop a grade 3 or higher adverse event. So those are things like electrolyte derangements, transaminitis, rashes that are severe enough. And so I think this is always a challenging decision, and a lot of it is based on how sick your patient is. If they're in the ICU on high flow nasal cannula, or even intubated, it's very hard to sit there and say, am I going to do less than the 15 milligrams per kilogram? But if you have pretty mild disease, then I think and they're starting to develop kidney injury or electrolyte derangements, this does make me feel a little bit better about using lower doses in those patients. So here's some of the plots looking at, again, the mortality is on the top. You can see that there's no substantial difference in the pooled analysis using a lower dose compared to a higher dose, and then that there does seem to be less grade 3 or higher side effects if you use a reduced dose.
What was the low?
Anything less than 15 to 20. Yeah. So it's a pooled meta-analysis. So some of these we're doing like 8, 10, 12. So yeah. All right, second case. So this is a 45-year-old with a history of hypertension, hemolytic anemia, following a course of antibiotics 5 years ago. COPD, he has pancreatic cancer, had a Whipple procedure, is receiving adjuvant gemcitabine, coming in with a chief complaint of dyspnea for 2 days, productive green sputum. He's febrile to 103, tachycardic to tachypneic on high flow nasal cannula at 14 liters, sputum culture, gram stain has gram negative rods, CT chest is shown, and a 1,3 beta-Gucan is sent in the ICU, comes back at 123 grams per milliliter, and you, the ID fellow, are called overnight saying, what do you want to do? Yep. Probably have gotten a call like this from Moffitt at some point.
To go back.
We're printing a selfie. You go back for a little bit.
Yeah. Okay.
How's that sound?
Central question. This one's a lot tougher than the last one, so. All right, so I've got 75% cefepime, 25% would start some sort of therapy for pneumocystis with trimethoprim-sulfa. A lot of things in here. So the hemolytic anemia following a course of antibiotics. I don't know if it's completely fair, but I did get this in a question bank before as being like, don't use Bactrim for this.
Spectrum.
Yeah. It was a pneumocystis question, actually trying to push people towards clindamycin, primaquine, and away from things like dapsone. I mean, sorry, not clindamycin, pentamidine, away from things like primaquine and dapsone, which are also associated with G6PD. You don't necessarily have to test someone for G6PD before you give them Bactrim like you do the other two agents, but the big thing from this question, I think most people caught on to it, is the patient's coming in with a lobar pneumonia, very atypical for pneumocystis. We have a gram stain showing gram-negative rods in a patient who's got COPD, risk factors for Pseudomonas, certainly. And then their disease state is pancreatic cancer. They're just on gemcitabine. They don't have any lymphoid deficits we know about. They're not on steroids. So there's no real risk factors for pneumocystis. And then the 1,3-beta-D-glucan we'll talk about in a little bit is a test that's looking for a component of fungal cell walls. It can be elevated in a number of fungal infections. So certainly disseminated candidiasis and histoplasmosis are the ones that are classic to have very high levels of 1,3-beta-D-glucan. Pneumocystis does too, but it's also a test that has a lot of false positives and it's very hard to interpret. And we'll go through some of those things. So cefepime is what I would probably say is the right answer on here. This patient has minimal to no risk factors for pneumocystis, and so I don't think they necessarily need to be treated. It's also a very hyperacute presentation, would be very atypical for pneumocystis. So before we kind of move on, this patient did, I made it up, but I mean, like they had Pseudomonas for the sake of the question. I think it is important to note Pseudomonas actually produces some Beta-Gucans in its cell wall. It's not just fungal organisms that make it. This is a study that looked at 47 patients with Pseudomonas bacteremia, and they just tested for 1,3-beta-D-glucan. They detected it in 12.8% of the patients. We know that Pseudomonas produces 1,2 and 1,6 beta-glucan, and it's kind of just presumed that Pseudomonas probably does produce 1,3 beta-glucan as well, either that or it's cross-reacting kind of the assay. So just something to know about, especially for Pseudomonal bacteremia, other gram negatives. It's, I guess, in theory, possible, is a possible risk for having a false positive test. In terms of 1,3-beta-D-glucan, its clinical utility for working up pneumocystis, I think, is important. This was a study from CID in 2011 in an HIV population. What they found is that a negative 1,3-beta-D-glucan, so less than 80, had a pretty strong negative predictive value. Or I'm sorry, it was very sensitive for kind of looking at pneumocystis. The negative predictive value still wasn't fantastic. It was 79.7, but at least you're getting into the sensitivities of the 90s, which is better than a lot of tests. So just know it's still not perfect, even saying negative, but it's performed certainly better than a positive. The specificity being 64.6% is pretty terrible. That's a very low threshold, right? I mean, that's the threshold for most tests. I think the one at Moffitt is 79 before it fires positive. So this is a similar study in non-HIV patients looking at pneumocystis and the 1,3-beta-D-glucan. It was a meta-analysis of 13 studies, and in that pool meta-analysis, they found that the sensitivity is worse in non-HIV populations at 85% compared to 92%. The specificity for both is not fantastic, 78 and 73. There's a lot of things that can be elevated in. We talked about other fungal organisms, Candida, histoplasmosis, bacterial infections, surgical gauze, actually. So a patient who's just had an intra-abdominal surgery IVIG or other cellular or blood-based products, you can have circulating 1,3-beta-D-glucan. So especially if they've had transfusions and things like that, which is usually the patients you're checking this on, that can make the test be positive. Albumin, cellulose filters for dialysis, those kind of things. I mean, classically, it was, the synthetic beta-lactams like piperacillin and tazobactam, but in the newer formulations for the last several years, that's not actually the case anymore. So don't get fooled with that anymore, but that's more of a historical thing. So this was another study looking at the performance of the 1,3-beta-D-glucan for patients at Sloan Kettering. They looked at all patients with malignancy who had unexplained lung infiltrates and a bronchoscopy with some sort of PJP evaluation. They looked at the patients who were PCR positive, was 53 out of 438. And then they compared the 1,3-beta-D-glucan to the PCR. So one of the things I want to highlight from this in all pneumocystis studies, I told you earlier, the CDC estimates the incidence of just being in your lungs is 20%. If you take it on people who died of traumatic things, you're going to have a lot of PCR positives. We don't have a gold standard. I mean, it's this kind of syndromic diagnosis of some sort of pneumonia, lung infiltrates, exclusion of other causes, and a positive test, because it can just be commensal flora in the respiratory tract. So they came up with some definitions, which is kind of what you do with when you're in that situation. Broke it down into definite, probable, possible. And the big thing just to take away from it is that the sensitivity of the test was very poor at a threshold of 80, so 69.8%. Specificity was also pretty poor, 81.2%. But it did have a much better negative predictive value in these patients with malignancy than the one I showed you before. So 95.2% compared to PCR positivity, which we already talked about. PCR positivity is going to overcall some cases anyway because it's just there. So less than 80 is decent in the hematologic patient or in the oncologic patient population for ruling out disease, but it's not super sensitive or specific. And you have to interpret a lot.
That's at like what level? Like what cutoff?
80.
80? Okay.
Yeah. They also did an analysis on a 200 threshold, and you can tell obviously the it's not going to perform as well the higher you go, and they kind of have the ROC curve over there with multiple different thresholds. So it takes a lot of interpretation. I think it can be helpful if it's completely negative, but any positive test, it gets very, very difficult to interpret, and you have to rule out other causes. This is a similar study from MD Anderson looking at patients from April 2014 to 2019. They excluded if they were already on PJP treatment for 4 days or they had a beta-D-glucan over 7 days prior to the bronch sample. They accepted both, or they compared again PCR to the beta-glucan assay. So a very similar test. The positive predictive value for a beta-glucan over 80 was in the single digits, but it did have a decent negative predictive value if you were less than 80 in terms of ruling out disease in oncology patients. So I think what I would take from it is, a negative helps you, but anything positive, it gets very, very, very difficult to interpret. All right, so getting into kind of the pathogenesis of the organism. Does anyone know, should you use Echinocandins to treat PGP? Why or why not, and any exceptions?
Target 1,3-beta-D-glucan. Does PJP have 1,3-beta-D-glucan? Answer is yes.
Mhm.
So the question is, why don't we use it?
Yep.
Resistance.
So
I was about to say, was this the one they found that it actually had worse outcomes if you treat?
no, we'll go through it. So basically the organism that we talked about originally when it was discovered in 1909, they thought it was a trypanosoma, and that has actually gone through the entire life cycle. It's still referred to as cyst and trophic phases, things like that. So the organism has this biphasic life cycle in the lungs. The trophic form, which is asexual, is the one that's predominant. It actually anchors to type 1 alveolar cells, and then it leads to a cystic phase that's sexual reproduction. The cysts express a ton of 1,3-beta-D-glucan. They express 1,3-beta-D-glucan synthase, and that's why certainly in patients with florid infections, you get very, very high levels of 1,3-beta-D-glucan. The trophic form does not. And you'll see here, this is a mouse model, so it's not Jirovecii, but it's similar organism in a different host. And the top is actually the cyst forms with multiple different echinocandins. So N-agulafungin green, caspofungin yellow, mycofungin is blue, and the bottom is the trophic form. And you can see that the echinocandins do exert an effect on the cystic form. Mycofungin's not great. It's the worst of any of them. And especially in panel B, you can see that it's not doing much. But N-agulafungin does seem to perform the best overall. And it does inhibit the cyst phase. The problem is that trophic phase that doesn't express 1,3-beta-D-glucan synthetase, so you don't have a target for your drug, you're not going to do anything to really inhibit the trophic phase of the organism.
So basically you just push everything to become trophic form. And then it can just exist or
not necessarily push. I mean, they have shown if you have a patient, if you have a mouse on an echinocandin, it can't transmit the disease. But at the same time, this was a separate study from the same group where in figure 4 up there on the top left, you see when they withdrew the echinocandin, the cyst did return.
Sure.
So that trophic phase shifts back into a sexual reproduction with the cyst form. And not only that, they could then inoculate other mice with cysts or with pneumocystis from the organism when the N-agulafungin was withdrawn and infect them with the organism as well. So at least in mice, they weren't able to, or they're kind of showing you, hey, you may be able to suppress it, you may be able to prevent it from transmitting, but when you withdraw that echinocandin, it can then go back. And so this is one of the reasons the organism, like you said, in infection, usually they have a high level of 1,3-beta-D-glucan from that cyst form, but there's a trophic phase of the organism which doesn't express the enzyme or the 1,3-beta-D-glucan. And so that's, the conceptual reason why you maybe shouldn't use an echinocandin. This was another study that was the same group looking at cultures of pneumocystis, which is extremely difficult to culture outside of the human body or diagnose. In a standard suspension or biofilm cultures, they also had to add basically, I think it was sheep serum at different concentrations to increase the yield. And they measured ATP production as a surrogate marker for fitness of the organism. And so same echinocandins, N-agulafungin, caspofungin, mycofungin. What you can see here is in the suspension cultures and to some degree the biofilm cultures that the echinocandins are able to, or especially N-agulafungin, is to suppress ATP production substantially. But once you start increasing the serum concentration, I think, the sheep's blood serum concentrations, it stops working at about 10%, even N-agulafungin. Mycofungin doesn't work at all, even at 1%, but N-agulafungin, you kind of lose that benefit. It's presumed that the organism, which it's an extracellular organism, but it does use a lot of nutrition from its host. And so the idea is, especially in humans in the lungs, you may have drug failures if you were to use echinocandins. And this was more of a, basic science bench research level showing you, as you increase the cellular products, you really start to lose any effect of the echinocandins, but an N-agulafungin is the most effective. So moving from rats to humans, this was actually a study published out of Taiwan of patients from 2015 to 2017. And it was 170 cases of pneumocystis. 78.8% got trimethoprim-sulfa, but they actually had a substantial amount that got N-agulafungin, which we know is active against the organism in some phases. And they found no difference in 60-day mortality. 32.8 versus a higher numerical, but not statistically significant, 38.9%. This is obviously very limited from a retrospective nature. A lot of these patients had probably some sort of immune reconstitution that, allowed them to control the organism or the infection on their own. If you can maybe suppress all the cysts and then your immune system can take care of the trophic phase, those are, fair questions, which you can't really answer with just a retrospective study. So just know that it has been used to treat the infection, but pathophysiology of how the organism's life cycle is, you probably don't want to use it if you can avoid it. This was just the baseline characteristics between the patients. So, you know, HIV infection in 20% overall, not too different from the two groups, a lot of hematologic malignancies, a lot of organ transplant. And then this was a risk factors associated with 60-day mortality. So receiving the Echinocandin with anti-Julifungin was not associated with a higher risk of death in the multivariable analysis. Not surprisingly, having worse oxygenation parameters was associated with a worse outcome. So kind of summarizing this, pneumocystis pneumonia in non-HIV patients, just know they may present more acutely, you know, instead of a month or several weeks, it may be a couple days to a week kind of thing, and they may be more severe. Their diagnosis is delayed, and so you have to have a higher index of suspicion and know what are those risk factors like lymphoid proliferative disorders or lymphosuppression in terms of like rheumatologic diseases, prolonged doses of high doses of corticosteroids, which I know we talked about earlier is going to suppress a lot of your cell-based immunity, a lot of that Th1, Th2 response, your CD4 cells. A lot of that's thought to be through IL-17A too, just kind of for recruitment of things to control the infection. And we know patients who get corticosteroids, even in HIV, their beta-Gucan levels in the lungs are higher, as well as their lymphocyte count in the lungs is lower. So it's a lot of things that go into it. It's not completely understood how corticosteroids set someone up, but we do know it leads to higher organism burden in the lungs, as well as decreased recruitment of cell-based immunity. Prophylaxis, so the IDSA guideline is going to say at a 3.5% risk. And they also explicitly say 20 milligrams prednisone equivalent for over 4 weeks. Knowing those specific groups who just always get prophylaxis, stem cell transplant, ALL on therapy, temozolomide with radiation. But in rheumatologic disease, the rate's lower. I mean, I think we tend to say, hey, consider pneumocystis prophylaxis, but just know that the rate is actually truly lower in those patients. And so we really need some better rolled and powered studies to see if there's a benefit. And then just recognizing that the 1,3 beta-Gucan, maybe it's helpful, it's negative, but it's just got a very poor positive predictive value. You should really only send that if you know what you're going to do with it. If you have a suspicion of pneumocystis and you're using it to get its strong negative predictive value in certain populations like malignancy. Otherwise, you're going to be stuck with this test that it's very, very hard to interpret what you're going to do with it. So that's kind of all I got. If y'all don't mind taking a few seconds, it's really short, like 5-minute survey, just kind of things you liked about the presentation or improve. And that can answer any questions too. Yep.
Any like info looking at like sensitivity, specificity of LDH cutoff levels?
Great question. I didn't find anything specifically. We know LDH does go up a lot with the organism. The problem is a lot of the patients who develop it also have reasons for elevated LDH, whether that's like cell turnover from malignancy. I'm not personally aware of any. I would think if it does perform better, it'd probably be in the HIV/AIDS population, but I'm not aware of anything in particular.
Hey, Guy, can I ask you a question?
I would assume it's not very specific, whatever it is. Sorry, there you go. Yeah, sorry. Pop up. There we go. Well, it's not gonna do it.
That works. So in terms of the rheumatologic disorders, doesn't it also depend on what the rheumatologic disorder is? Underlying,
Yeah.
like PMR patients get high dose, or
Yeah.
GCA patients get high dose steroids for a long time.
Yep.
But they very rare to get PJP, whereas like a Wegener's much higher risk.
Yeah. So the that study I showed you, they weren't able to in a multivariable show the highest risk conditions, but they kind of were talking about what you were saying, the microscopic polyangiitis, those are the ones that are going to get much higher doses of immunosuppression. They're also a lot of times going to get B-cell depleting therapy on top of it. Yep, rituximab, which is going to be like another risk factor too. So you're absolutely right. That's going to be a lot more cell-mediated issues in addition to just the corticosteroid. And so knowing they probably have a higher risk, we would just need to a better controlled powered study to that.
Yeah.
We have a patient on our team right now that, that he had like low suspicion, he had HIV uncontrolled, low suspicion of PJP, but he's discharged on Beta-Gucan because he has a Bactrim allergy, doesn't like the taste of the phone. So they put him on that and then said after the treatment of that, then go to Dapsone. He's a prisoner. I think there was some miscommunication on discharge that he was started on Dapsone immediately when he left. So Primaquine and Dapsone. And then he came back for nausea, vomiting, a couple other things, but he had 20% methemoglobinemia.
Yep.
So we stopped everything, but I mean, now I'm not sure if it was because both of those, Primaquine and Dapsone, were used simultaneously, but I mean, those both can cause methemoglobinemia. What I read, etobicoline can also cause it. Allergy to Bactrim. I mean, I'm not sure if inhaled pentamidine can do that, but it's kind of like we're limited on options now.
Yep. Yeah. So to completely sidestep the issue, you can go to pentamidine, but that's like a month. Like you said, it's a monthly thing, and that technically is going to get difficult.
This is daily pentam though for severe infection.
For treatment, but prophy. Yeah.
Okay.
Yeah, exactly. So that one's going to be Dapsone's probably the culprit. So I mean, you could argue like restarting the other one first and just kind of watching. Probably in combination, they're not great, but like Dapsone's classically the one that's associated with it. So
You just have some comments in the chat about the screen.
yeah. So from the chat, Dr. Green was noting too that the beta-glucan over 500 with ground glass pneumonia always equals PCP, and they have it on the BAL when they go to first case and third cover. Yeah, and that they had a breakthrough case with inhaled pentamidine, which is kind of known too in the prophylactic studies. It's inferior to Bactrim as prophylaxis, and same with Dapsone. The beta-glucan over 500. I mean, I certainly get suspicious too in the right patient who's got a bilateral, not bilateral, but like a interstitial pneumonia and the classic risk factors with it. And I'm as guilty as anyone. I probably send more Fungitels or 1,3 beta-glucans than anyone of doing it. It's just it requires a lot of interpretation when you get it back. And I agree when it's over 500 in the right patient, you really start to suspect it. I had I think Dr. Montero saw it too, but I had a patient in here at TGH who had aspergillus growing from multiple respiratory cultures of cavitary pneumonia with lymphoid malignancy, getting brentuximab, and I think he got rituximab too in the last 6 months. And he actually even ended up having a spontaneous pneumothorax as well and interstitial pneumonia. And I treated him for pneumocystis as well. The challenge is, 1 out of 5 people are going to be PCR positive in the lung. So, certainly some of those are going to be colonization, but it also there's no gold standard. And that's one of the challenges too, is so I agree if they're, 1,3 beta-glucans that high and with risk factors, with all that, you're going to treat it. And there's nothing I can tell you is 100% sensitive to, 100% specific to rule the disease in. So it does get challenging a lot of times. And I certainly have treated people that I can't definitively rule it in or out too.
We just had a case of Moffitt, beta-glucans greater than 500. Just after receiving Ritux, he just crashed.
Yep.
What do you think about the LDH? Comment on that?
It's very hard to use for heme malignancy patients because it just can trend so much with their cancer itself.
Yeah.
So I don't have a lot of great things. And even in like HIV/AIDS, there's other things that overlap. We don't have a lot of histoplasmosis here, but that's always got to be in your differential for someone with a pneumonia and HIV/AIDS with an LDH elevated. Disseminated MAC for any of the other non-tuberculous mycobacteria, you may have a little bit as well. Certainly you'll see in the HIV/AIDS patients, you're entitled to multiple opportunistic infections at one point in time. So I think it's a very non-specific test, but if I have a patient with this type of pneumonia and their LDH is 500 or 600, I get worried about pneumocystis, especially if they have an interstitial pneumonia.
I had a patient recently with HIV/AIDS, CD5, came in ground glass opacities. The LDH was only like 250.
Mhm.
Then the Fungitel was greater than 500.
Yep.
And Bronch confirmed PJP.
Yep.
Just kind of, extensive ground glass opacities. So there was some debate between me and my attending, like, was this PJP versus something else because
Yep.
LDH was low.
So I would never use an LDH to rule it in or out. Like for that patient you just said, like, if they had any risk factors for pneumocystis and they had a pneumonia, I would treat it as sepsis.
Yeah, I would want to tell them more than 5.
Yeah.
Compatible.
Yeah.
Radiographic.
But it does bring, that does still highlight the problem of like, there is no gold standard in all of these studies. You're coming up with a consensus definition.
Yeah.
Meeting both like micro criteria, some sort of host criteria and clinical criteria, and then kind of going from there because we don't have a gold standard that's 100% specific. Yep.
That a curious test has picked up colonized patients that were solid tumor low risk and CT chest did not match. And he said that he did not treat.
Yeah, no, I definitely agree with that. Especially that's one of the things I really like about that CID study is they took patients who had absolutely, like, no one would ever in a million years consider them having PJP and just showed how many of them were PCR positive in the lungs. And so on autopsy. And so, you just have to recognize it is a commensal organism that, it can certainly cause infections in the right host. And so just isolating it on a test like that just does sequencing for cell-free DNA and plasma, or especially in respiratory samples, how you're going to interpret it. I can say that in mammals, the organism is almost exclusively in the lungs. So that does bring up the concern of, well, if I'm detecting cell-free DNA in the plasma, is something going beyond the lungs? There's nothing validating the carriers for that. And so I would agree in a patient who doesn't have any sign or symptom of pneumocystis, if it popped up on a cell-free DNA test, I would probably ignore it too. There have been some, published studies that have shown disseminated pneumocystis, which is extremely rare, but those patients have a lot of lung structural damage too that leads to that kind of dissemination into the kind of the bloodstream component or compartment. So, it's possible, but that's extremely rare. In almost all cases of pneumocystis, it's almost exclusively limited to the lungs. And that's like we talked about, right? Like the trophic form anchors to type 1 alveolar cells. That's its pathogenesis. And so that's certainly kind of where the organism sets up shop. So, all right. Any other questions we can answer? Awesome. Well, thank you.